Evidently, I get two microphones. Hi, everybody. My name is Craig Coopersmith. I'm going to talk to you about COVID-19, a review of pharmacologic management. I've been told in advance that if people have questions, you should speak them into the microphone, because everybody has a microphone, because evidently this is being recorded. And if I speak, but nobody hears the question, who's ever listening to this somewhere won't know what you're saying. Before I get started, I'm going to read to you a piece of paper that I got, which is really important. Session formats. I got this from Jean-Louis. Tutorial, a simple guide to. Informal teaching session, primarily dealing with practical aspects. Dialogue with the audience is encouraged. Projection and board can be used. Please note, this is very different format than a standard presentation. So I took that to heart, and so although my slide deck has like 60 slides in it, there's actually only like 10 or 12, because what I did is I put everything at the end. If somebody said, hey, what's the data on steroids or tocilizumab or baricitinib, I could be like, well, the Cove barrier trial shows this, or recovery shows this. But I took this to mean what it actually said. Interactive session, not with me standing up here and all of you guys over there. So I will give some slides, and I thank God that at dinner last night somebody mentioned to me that I should, because I had planned to literally just do interactive. So I'm happy about that. You know, I did that for the last couple of hours. But my understanding behind this is that we're supposed to be interacting. So having said that, we will get started. So these are my disclosures. I sit on the NIH COVID guidelines in the United States. None of us speak on behalf of the guidelines, but I am a member of the guidelines, so everything I show from the guidelines in the United States, I am a guideline member. And in addition, when the WHO was coming up with different drugs to test for the Solidarity trial, I was on a subgroup that basically said these are appropriate immunologic and pharmacologic targets to go after. So I'm speaking on behalf of myself, though I have advised the WHO, and I'm actively involved for the last 3 years, multiple hours a week, every single week, with the NIH COVID guidelines. So as we talk about pharmacologic treatment of COVID, and again, I'm not going to talk about how we do mechanical ventilation. This is specifically about the drugs. I'm happy to answer a question if somebody has, but this is solely pharmacologic management. We can first start with the concept that this is sort of precision medicine and it's sort of not precision medicine. We heard at the opening summary this morning that ultimately you want to get down to the very tall order of very specific things for very specific patients. And what we've learned from COVID in some ways clearly is that one size does not fit all, but we have brought it down to nothing further generally than subgroups, although sometimes there's biomarkers involved. So it's a very simplistic way of looking at it. Earlier in the disease, when COVID is present, typically before we ever meet the patients, we target the virus. And by the time that somebody gets to us in the ICU, we're targeting the host response. And so when I go through the paradigm of how sick a patient is, that we change drugs along the way, it's sort of precision medicine, because we're not saying somebody has COVID. We're making the distinction of they have COVID, they're not in the hospital. They have COVID, they're in the hospital and no oxygen. They're on oxygen. They're on high flow or non-invasive. They're mechanical ventilation or ECMO. We're very clear that those patients are not all the same, and so it's precision medicine in that sense. It's not in the sense that we're saying mechanical ventilation, and that's the whole thing that people were talking about this morning. Somebody in mechanical ventilation is not somebody in mechanical ventilation. Somebody in high flow is not somebody in high flow. We could have different genetics, different environments and everything, and we don't have that degree of precision. But we do have the degree of precision in saying when we treat somebody with COVID, it makes a huge difference how sick they are, what we do. Issues with giving this talk today. I'm not going to go through every study, although I'm happy to if somebody says to me, hey, let's talk about a certain study. Like I said, I've got 50 hidden slides at the end. But the truth is, as COVID has gone on, our treatment has changed. And so if somebody says, well, the first study in tocilizumab was negative, That's true. And that's before anybody used steroids. If somebody says, what did the first study on baricitinib show? The design in the New England Journal of Medicine was baricitinib and remdesivir versus baricitinib. Versus remdesivir. There was no steroids. So as time has gone along, looking at data, if we talk about sepsis or ARDS, data from 3 years ago is very, very recent. If we talk about COVID, data from 2020 or even 2021 is ancient because we've treated the disease remarkably different as time has gone on. The next is COVID itself. The virus itself has changed throughout the course of COVID. So we say COVID, but we're not treating Alpha anymore, and we're not treating Delta anymore. And in fact, how many of us in this room have masks? 0, right? Not a single person. So a couple of years ago, when ISICEM was supposed to happen, the meeting didn't happen. The first time we had ISICEM, it was in September or October. It was my first meeting after COVID, or it was still part of COVID, and we were all mandated to wear masks, right? Anybody who was at that meeting was mandated to wear a mask. You had to show your vaccination card. You had to do all this stuff to get in. And I'm looking at this room, and it's a year and a half later, and not one person, not one, is wearing a mask. I can't speak to the room next door. But I haven't seen anybody in this meeting wearing a mask. So COVID isn't COVID. Omicron isn't Delta, isn't Alpha. If you look on the microbiological basis, if you actually look at the virus has mutated enough over time that what we think would work in version A versus version B is totally different. Monoclonal antibodies used to be fantastic. Monoclonal antibodies don't work at all now because of variants that have happened over the course of time. Many studies exclude critical care. Perhaps that's not surprising. Why separately? Why are there so many cancer trials but so few critical care trials? Anybody know? This is our interactive time. Anybody know? I'll interact with myself. Yes, it is industry driven, and in large part, it has to do with the fact that if we have a negative trial and we are about 0 for 200, 250, 300 over the course of just about every drug in critical care, industry doesn't want to pay for another trial in critical care because it's unlikely to be positive, and also it's what you spin as a positive trial. If you're in oncology, and I'm not whacking on my friends in oncology, we can learn a lot from them. If somebody has a 2-week improvement in survival, they celebrate and they say, let's put this on the market and pay 50,000 euros. I want to say dollars, pay 50,000 euros for the market. And everybody's like, hooray, we're so great. We expand the lifespan by 2 weeks. And everybody considers it a positive trial. We don't. That's how industry works. They fund things that they're going to be able to sell. Things generally don't work very well in critical care. So COVID is interesting and unique in that the entire world got together for a couple of years. But in general, when somebody's trying to do a trial, they will do anything humanly possible to exclude people on mechanical ventilation and exclude people on ECMO because the trials are much more likely. So if we get back to our previous concept, if you get somebody early in anything, you're more likely to do better than if you get them late. What's the best treatment for getting hit by a car? Don't get hit by a car. Exactly right. That's the best treatment. What's the best treatment if you get COVID? Don't get COVID. But if you're going to get COVID, treat with Paxlovid before they ever come into the hospital. By the time somebody is gone through, I'm in the hospital, I'm on oxygen, I'm on either high flow or non-invasive, I'm now on the ventilator. What? Oh, first person in the mask, thank you. So by the time you get to that, it's the same thing as what's the best treatment for sepsis. Well, if you treat an infection before you become sepsis, you're going to do much better than when you have multi-system organ failure. So most of the trials are actually not in the ICU. And show of hands, who right now in your ICU has more than 10 COVID patients? Doesn't matter. I'm asking everybody in the audience, who here, I'm in charge of 330 ICU beds. I want a show of hands who has more than 10 patients, COVID patients currently in their ICU. Show of hands who at any time during the pandemic had more than 10 patients in your ICU? Okay, right? So we had 150. We had 6 today. And I'm going to get to that in a minute because those 6 aren't there because of COVID. And so as I'm talking about pharmacological management, this would have been a great talk to give a year ago when we actually had COVID patients in our ICU. But I was asked, and here I am. Interactive, sort of. So, as I mentioned, there's multiple guidelines. I'm going to talk about 2 of them. I'm going to talk about the NIH guidelines, and I'm going to talk about the WHO guidelines. They are very similar because the data are the data, and they are not the same. The WHO guidelines have been updated 19 times. The NIH guidelines have been updated 54 times, which is why I meet multiple hours a week. And I can also sort of give you a sneak peek at what the next version is going to look like off the record, but I can't actually say anything other than what's published right now. So what's published right now is 14 days old, and I can already tell you factually that we have another version. We always have another version in the hopper. So, oh my God, I can't read this from here. So this will be interesting. What is the most common patient in the ICU now with COVID? Anybody? Incidental, right. So post-op is legit. Immunosuppressed for sure is legit. But by far the most common patient in the ICU right now is somebody who, I don't know about your hospitals, my hospital literally 2 days ago sent out a memo saying we're not going to test everybody anymore. And they also said we don't have to wear masks on rounds. We have to see it with the patients. That was a fundamental change because I haven't seen anybody I work with in 3 years. But we're going to stop incidental testing. But we've done incidental testing ever since testing's been available. And so we have a huge number of COVID patients in our ICU that are there because of a subarachnoid hemorrhage. And when they have their subarachnoid hemorrhage, I don't actually work in a neuro ICU, so not in mine, but when they have their subarachnoid hemorrhage, they test positive for COVID. Or we're doing surgery on somebody, and it's an emergent surgery. And then you look and it turns out they're COVID positive. By far the most common indication for being in the ICU right now with COVID is something else, not COVID. Although for sure, the person who said immunosuppressed, for sure, I agree with you. For sure, immunosuppressed vaccines don't work if your immune system doesn't work or don't work nearly as well. And a lot of the drugs that you might want to give to an immunosuppressed patient on an outpatient basis interfere with their immunosuppression. And they can't take, if I got sick, I could take Paxlovid. A lot of them can't because it interferes with their liver transplant medicines. So that's probably the second most common. The most common is incidental. And how do we treat patients with incidental COVID in the ICU? We don't. Right. And so this is what the NIH thing says here. And again, I wish I were younger and my eyes were better because normally the computer's in front of me. But basically, what it says to do, and the very top thing is hospitalized for reason other than COVID. You don't go to the treatment at all for COVID, for inpatient. You go to the treatment for non-hospitalized high-risk patients. It's a totally different part of the guidelines. So somebody's in an ICU, and you treat them for a non-hospitalized thing, and what do you have here? Paxlovid, potentially remdesivir. So the majority of our patients in the ICU don't need to be treated at all or need to be treated if they're high risk with something very, very early, which is such a fundamental paradigm shift. These are the patients who are in the ICU for COVID. Again, this would have been a great talk to give 2 years ago when we couldn't be together, or even a year ago when we actually still had patients somewhat in the ICU with COVID. What do we do for patients who are in the ICU because of COVID? These are our ARDS patients. These are our ARDS patients who have lots of thrombosis, that we heard about that this morning. So every one of them, basically, unless there's a contraindication, should get dexamethasone. And unless there's a specific reason, again, this is the NIH, there's little differences between countries, they should be getting a second agent, and the second agent should either be baricitinib or tocilizumab. And you'll look at the strength of the grading there, and it's pretty lousy. So dexamethasone gets a strong rating, A1 I think it says, and both Toci and Barry get a B2. Because again, when you look at the studies, that's why I was making the distinction in the studies about what's an ICU study versus what's not an ICU study. If you take all comers and you look at the recovery trial, the solidarity trial, or remap cap, whatever else, you're going to find it's about 13% or so of people not on oxygen, 30 or 40% of people on conventional oxygen, 30 or 40% of people on high flow or non-invasive, and 10 or 15% of mechanical ventilation, or mechanical ventilation is an exclusion. So we don't actually have great data on patients who are our patients. The sickest ones are the ones who are almost universally excluded or make up a tiny portion of the actual studies, or they're small studies. Like there's a great study in baricitinib with 101 patients. The big studies, the 8,000 patients, aren't those. They're pragmatic studies. And so it's not strong evidence, but what we do have is somebody in ARDS, somebody who's on the ventilator, steroids, and then with relatively weak data, either adding Barry or Tosi. Do we do both of them at the same time? There's no data. I mean, there's like subsets of studies of people who've been on both, and it seems safe. If you talk to the rheumatologists, they politely lose their mind because they're like, it's going to be a tremendous problem with secondary infections. And the truth is, if you have 100 patients who've done it, how can you actually tell? And so the truth is, we can't tell. We're not recommending it because of that concern. So one or the other. These are patients who were previously commonly in the ICU, and this is a group that we actually do have good data on. So these are the patients who are on high flow or non-invasive. And what do? Again, everybody gets dexamethasone. Above and beyond dexamethasone, once again, we're giving baricitinib or tocilizumab, but they don't have the same evidence base here. The baricitinib data is much stronger than the tocilizumab data. So, spoiler alert, this might change in ranking in the future, hypothetically. But right now, the baricitinib data gets an A1, and the tocilizumab data gets a B2A. So lower strength of recommendation, lower quality of evidence. There's two large randomized controlled trials of baricitinib in the steroid era. There's one prior to the steroid era, but there's two large that show a significant improvement in survival in this sub-patient population. And we're not talking about a couple of patients. Usually, again, most of the big trials had a significant number of patients on high flow or non-invasive, did not have a significant number of patients on a mechanical ventilation. Tocilizumab started as a negative trial, then you added steroids and it became positive trial, followed by positive trial, followed by negative trial, followed by positive trial. So the data gets downgraded because the data is not all in the same direction. You have the preponderance of evidence is not the same as every trial shows the same thing. And so when you have somebody on high flow, or if you have somebody on non-invasive, it's similar, but you would actually probably prefer Barry. And this is where you see the word remdesivir. So remdesivir, there's been 4 large randomized controlled trials. You'll notice it did not say anything about remdesivir mechanical ventilation. Again, I can't read the slide, but I know the data, other than maybe don't use it. And that's because in the Solidarity WHO trial, remdesivir actually increased mortality in mechanically ventilated patients. But there's a lot of trials earlier, ACT1, CATCO, Pine Tree, et cetera, that shows that remdesivir given earlier, when it interferes with viral replication, could be beneficial. This is probably about the cut point. There's not great data. There will be some people who will say, I'm giving it immunosuppressive, I'm concerned about viral replication, therefore I want to give it antiviral. And there'll be other people who will say, you know what, if you actually look at the data is kind of crappy in this patient population. The data is good in earlier patient populations. For the sake of completeness, I have these here. Patients not in the ICU unless there's an unusual reason. So these are patients who are on supplemental oxygen. And the next slide is people who aren't on oxygen at all. Who here takes care of patients with COVID who are not on oxygen? So I can basically skip these, right? The only reason I have these up there is because if anybody ever wants to look at the slides later and they don't want to go to the website, because the website is, I think it's up to like 700 pages now. This all comes from one table, but it literally is up to 700 pages, again, 50 some odd thing. But this will tell you earlier on, what do you see earlier on? Are you seeing baricitinib and tocilizumab? Only if somebody's rapidly progressing and you know they're going to be in high flow in a couple of minutes. You're otherwise not seeing them. Here you are seeing remdesivir because earlier on, remdesivir is beneficial. And then when you get really early, what do you see? Somebody's admitted to the hospital, we recommend against the use of steroids, other than systemic in the setting of COVID-19, and remdesivir. So fundamentally different disease, right? We go from don't use steroids, even though at least in the United States, and I hope you're smarter in Europe, I tend to believe you are, we have a tremendous number of our general practitioners who are giving outpatients dexamethasone. And we know that because we have big databases, because we have the federal government, the VA, the veterans, that you can actually look at hundreds of thousands of people. And we have all these people with outpatient settings who are getting prescribed steroids, which is wrong. And I'm not going to go through the data other than to say when you gave dexamethasone in the original studies, it actually caused increased mortality in outpatients. You know, people hear and they don't do the precision medicine thing. So the truth is you start at Paxlovid and then you go to remdesivir and we never see the patients. And by the time we see them, everybody should be on steroids. And by the time we see them, everybody basically should be on either baricitinib or tocilizumab as long as you have the availability to get it. If not, you can use tofacitinib or sarilumab. I did not practice saying that. So in the couple of minutes I have left in our interactive, and I'll put that in air quotes, session, this is the WHO guidelines. These were much more different when I spoke on this last year, because I did speak on something related to last year. Because last year there was a big disconnect between Europe and the United States, specifically in only one drug, and that one drug was remdesivir. So many people, most people in Europe thought that remdesivir was absolute garbage a year ago. And the United States was much more pro, and it shouldn't be like a one, and well, Europe's a continent, the United States isn't. It should be one versus the other, but there was a huge difference in, and I tried to go through the data in terms of what people prioritize. Because ultimately, the data are the data. There isn't European data or United States data or Australian data. The data are the data, right? But people can prioritize a study more. They can prioritize, this is an RCT versus this is a poorly controlled trial, but with more people. This is a trial that has 20,000 people, but we can't control as much. What you can consider more, you can view it one way or the other. But since then, again, everybody, to get into the New England Journal and JAMA and Lancet, you usually have to have a cool acronym. You know, CATCO came out and Pine Tree came out. Act 1 is not a cool acronym because it comes from the NIH. The NIH doesn't do cool acronyms. But ultimately, multiple studies have come out that have shown that actually remdesivir does improve outcomes earlier on. And so with this, we now have a different way of looking at it. This is the WHO guidelines. And they break it slightly differently, right? So they break this into non-severe, severe, and critical disease. So you can see what you have over here. Absence of signs of severe critical disease. Severe is oxygen. I don't consider that to be severe. We have the ordinal scale, 4, 5, 6, 7. And then critical is, you know, what we're taking care of. And what you're seeing over here is strong recommendations. So strong recommendations are exactly the same as what I just said. Steroids, tocilizumab, or that could also be sarilumab, and baricitinib. The WHO guidelines say may be combined, not should be combined. I agree with that. May be combined. And then again, if you look to the left, it's covered by their update. This is not something I did on my computer, but this is the way it looks right now. You have Paxlovid, but Paxlovid is for the non-severe. Again, who do we take care of? We take care of patients on the right who are critical, and maybe we take care of patients in the severe, depending upon what the entry criteria are to your ICU. I did not talk about what we go against. There's about literally 30 or 40 or 50 or 60 agents I used to put from the NIH that we recommended against, but they're not in our big table. You have to actually go do deep diving. The WHO, actually, you don't have to do deep diving. They'll actually tell you specifically what they're recommending. And so this is weak against. The next one is going to be strong against. Again, for ours, up top you see tofacitinib. But again, if you read the fine print, that's basically saying only if you don't have tocilizumab. You should use tocilizumab, and tofacitinib is baricitinib is only if you don't have it. Ivermectin is a weak. I'm sure at some point that's going to become a strong. There's a question to how many randomized controlled trials can show the exact same thing over and over and over again, that ivermectin does not work. convalescent plasma does not work in critically ill patients. For the person who brought up immunosuppression before, there is still a question about insufficient evidence of high titer convalescent plasma in outpatients, which is totally irrelevant to this discussion. For our discussion, convalescent plasma in the ICU does not work. These are the things that are strong against. Again, they have that thing that covers it up, but all the monoclonal antibodies that used to work don't work anymore because the variants went from being totally sensitive to totally resistant. So companies that were going to make a fortune 2 months later were kind of out of business because their monoclonal antibody killed everything, and it was a wonder drug, and then it killed nothing, and it got taken off the market. The other ones that you're seeing here are hydroxychloroquine, where there's an incredible amount of data on hydroxychloroquine. These are two things that you may or may not be aware of, and I'm going to finish on this. These are two drugs that are well-done studies that are not published yet, despite the fact that this press release came out in June of 2022. But that has something to do with the journal's decision of when to publish, as opposed to when the data is out there. So this is two drugs. One is infliximab, which you might know as Remicade, anti-TNF, and one is abatacept, which you might know as a different name that I can't remember, but ultimately blocks CTLA-4 and blocks a second signaling on T cells, T-cell signaling. Here's your bottom line. The bottom line is both of them in single but large, well-done, randomized trials, this is from the press release, improved survival, which actually wasn't necessarily the primary endpoint, but 500 patients in each arm, both of them improved survival. So they've been available as a preprint for a really, really, really long time. We know what our recommendation is going to be in the United States when this finally gets accepted into a major journal, but it hasn't been accepted into a major journal yet, and we're not publishing anything based upon preprints, but everybody can go up to these to see that these are two studies, these are the titles of them, and I'm going to just give you, I think in my last two slides here, because it says I'm out of time. So the first is infliximab. Again, infliximab, also known as Remicade, also known as anti-TNF. You probably have patients who are on this for Crohn's disease. This is 1,000 patients, 517 with infliximab, 516 placebos. And you look at the conclusion, you can take pictures of the whole thing, but did not demonstrate statistical improvement in time to recovery. That was the primary outcome, but had improved 14-day clinical status and a substantial reduction in 28-day mortality compared to standard of care. And again, this actually included our patients. I wouldn't be showing you this if this were like somebody on oxygen, not in the ICU. This includes our patients. It actually improves survival. Single study, but still a big study. This was actually done at the exact same time. It's the same group, it's the same authors, platform study. This is looking at abatacept, which again prevents the secondary signal in your T-cell signaling, binds to CTLA-4. Again, a little over 1,000 patients. If you look at the bottom, addition of a single dose intravenous abatacept to standard of care demonstrated no statistically significant change in time to recovery, same issue, that was primary, but improved 28-day mortality. For those who've never taken care of somebody with abatacept, and I don't remember ever taking care of somebody, I certainly have people on Remicade or infliximab, this is a drug that's approved for rheumatoid arthritis. So for those who have a lot of patients with rheumatoid arthritis, you might be familiar with it. If not, it's another immunomodulator, but it's an immunomodulator that we don't see as much that also improves survival in COVID. I have this, if you can get it, the dosing. I'm not going to go through this all right now. But the thing to remember with baricitinib, it is renally cleared. The beautiful thing about baricitinib is you can take it orally, which as long as your patient's gut works is great. The downside to it, it is renally cleared. I'm assuming that everybody in here knows how to dose dexamethasone. Tocilizumab is typically a single IV drug, although if you actually look back at the study, some of them say, we gave a second agent. We gave a second drug dose when they wanted to. So it's either a single dose, and if people aren't doing well, people will give a second dose. It is IV. They're equivalently expensive depending upon how your hospital works. Heparin, we heard about this morning. So I didn't say anything about heparin. The reason I didn't say anything about heparin is in our patients, it's prophylactic, not therapeutic. Again, 2 studies in the England Journal of Medicine, and now one that came out this morning, I guess, in JAMA, showing that whether you do the simple analysis or the more complex analysis, therapeutic heparin doesn't work. And then following remdesivir, which again is not really an ICU drug, that's it. They just turned off my slides, but it's good because my next slide was going to say thank you. I'm assuming since you turned it off that I don't have time for questions. Oh, I do not.